Hello friends, welcome to Creative Medicine. In this lecture, we will learn about pancreas. So in the pancreas, first we have pancreatic division. So pancreatic division, this is the most common congenital anomaly of the pancreas. So most common congenital anomaly of the pancreas is pancreatic division. So in pancreatic division, it is characterized by divided drainage. Normally, if you see the main pancreatic duct, this will be the main pancreatic duct will mainly the main pancreatic duct will drain the whole part of the body along with the head, and it gets drained into the major duodenal papillae, whereas the accessory pancreatic duct will drain into the minor duodenal papillae. Okay, along with the main pancreatic duct, even the bile duct will come, and also common bile duct will also come and drain through the major duodenal papillae. So this is what normally seen. But if there is pancreatic division, this communication will be lost, and here the the head of the pancreas will be right. The head of the pancreas will be drained by the head of the pancreas will be drained by only the accessory pancreatic duct, whereas this part of this body and the tail will be drained by the main pancreatic duct, like this. Okay, so this is called as pancreatic division. This is pancreatic division. Okay, the major part of the pancreas is drained by the accessory duct of Santorini via the minor papillae. So this is accessory duct of Santorini. This is accessory duct, and via minor papillae, main part of the pancreatic duct is drained, whereas this part, the small part of the pancreas, that is only the head of the pancreas, is drained by the major duct of Varsang via the minor papillae. So this is pancreatic division. Then what are the clinical features? Because of this varied drainage, the patient suffers from recurrent attacks of acute pancreatitis. Then investigation of choice is MRCP, and in these patients, so if you see, gold standard is actually ERCP. You should do endoscopically, you should do sphincterotomy should be done. So here you will do endoscopic sphincterotomy is the treatment for these patients. You can either do dorsal duct sphincterotomy or dorsal duct sphincteroplasty can be done. So this is pancreatic division. The next important thing in the pancreas is annular pancreas. In annular pancreas, the ring of the ventral pancreas is seen around the part of the duodenum. Here the ventral pancreas will surround again around the duodenum like this. So there is ring of the ventral pancreas is seen around the second part of the duodenum. Okay, it is located mainly proximal to the ampulla. It is located proximal to the ampulla, and this is associated with Down syndrome, and it is associated with duodenal atresia. It is associated with either Down syndrome and duodenal atresia. So if you see the clinical features, in the clinical features there is non-bilious vomiting is seen. This non-bilious vomiting occurs because the obstruction is proximal to the ampulla. So you see non-bilious vomiting. Then the investigation of choice is ERCP is the investigation of choice. Then what is the treatment of choice? Duodenostomy is treatment of choice more than duodenojejunostomy. This is annular pancreas. Then we have next important disease is duodenal atresia. Duodenal atresia is actually the most common cause of intestinal obstruction. Especially it is most common cause of intestinal obstruction in the neonates. Okay, it is located mainly distal to the ampulla. It is located distal to the ampulla, and the patients will have bilious vomiting. Here the patients will have bilious vomiting. The treatment of choice here is duodenostomy followed by duodenojejunostomy is the treatment of choice. Then the next important thing is about acute pancreatitis. So if you see in the acute pancreatitis, what are the causes? Most common cause of acute pancreatitis is gallstones more than alcohol. Then we have other causes also like blunt trauma, ERCP, hypertriglyceridemia, hyperparathyroidism, hypercalcemia, carcinoma of pancreas, cystic fibrosis, then viral infections also like cytomegalovirus, mumps virus, echovirus, and many drugs can also cause acute pancreatitis like 6-mercaptopurine, azathioprine, D-inosine, citarabine, aminosalicylic acid, tetracycline, pentamidine, estrogen, and trimethoprim sulfamethoxazole. And we have thiazide diuretics, then we have valproate, then we have furosemide, then we have metronidazole. So all these will cause definitive association with acute pancreatitis. That is 6-mercaptopurine, azathioprine, deoxycytosine, then we have citarabine, aminosalicylic acid, tetracycline, pentamidine, estrogen, trimethoprim sulfamethoxazole, thiazide diuretics, valproate, furosemide, and metronidazole. These will increase the risk of acute pancreatitis. Then we have possible association. Association is L-asparaginase and also acetaminophen. L-asparaginase and acetaminophen, these have actually possible association with acute pancreatitis. Now, if you see the pathophysiology, here there is abnormal intrapancreatic activation of pancreatic enzymes will be seen. Pathophysiology is abnormal intrapancreatic division. Pathophysiology is abnormal intrapancreatic. There will be abnormal intrapancreatic activation of the pancreatic enzymes will be there, and these intrapancreatic activation of pancreatic enzymes, these will, because of the activation of the pancreatic enzymes, these will cause damage to the ductal acini, and they cause mild and self-limited injury in majority of the cases. If the patient has mild acute pancreatitis, then there will be less than 1% of mortality will be there. If the patient has severe acute pancreatitis, then the patient will have 10 to 30% mortality will be seen. And we also have gallstone induced pancreatitis is seen, and this gallstone induced pancreatitis has the best diagnosis. These pancreatic enzymes have lipase which digest the fat of greater omentum, and once the fat of the greater omentum, the pancreatic enzyme also contains lipases. These lipases will digest the fat of the greater omentum, and it converts into fatty acid and glycerol. These fatty acids will combine with the calcium, and these result in chalky deposits are formed. And thus this will result in these chalky deposits will undergo saponification. Saponification will occur leading to hypocalcemia will be seen in these patients. Then if you are asked what is the most common cause of death in acute pancreatitis, if it is within 2 weeks, the most common cause of death in acute pancreatitis is multi-organ dysfunction syndrome. If it is after 2 weeks, the most common cause of death is sepsis. Within 2 weeks, the most common cause of death is multi-organ dysfunction syndrome. After 2 weeks, the most common cause of death is sepsis. Then, if you see the initial sign of multiple organ dysfunction syndrome is impaired lung function is the initial sign of multiple organ dysfunction syndrome. Impaired lung function is the initial sign of multiple organ dysfunction syndrome. Now, if you see the clinical features, you will see that there will be epigastricum. There will be pain in the epigastrium which will be radiating to the back, and partially this pain is relieved by sitting and also by leaning forwards or bending forwards. This pain will relieve. Okay, initially the pain is in the epigastric region, and then it is radiated to the left side of the back, and partially this pain is relieved by bending forward or in sitting. So due to paralytic ileus, there will be nausea, vomiting, abdominal distension. So in these patients, due to paralytic ileus, you will see that the patient will have nausea, vomiting, and abdominal distension. Now, what are the signs of the paralytic ileus? So if you see the signs, one, you will see presence of gasless abdomen will be seen, and also there will be ground glass appearance, and sentinel loop sign will be seen. Ground glass appearance, gasless abdomen, sentinel loop sign, and colon cut off sign is seen. This is also associated with the left-sided pleural effusion. Now, if you see, hemorrhage is rare in these patients, and we have Cullen's sign is seen. What is Cullen's sign? Cullen's sign is presence of ecchymosis around the umbilicus is called as Cullen's sign. Then we have Gray Turner sign. In Gray Turner sign, the presence of ecchymosis in the flanks, we call it as Gray Turner sign. Presence of ecchymosis in the flanks, we call it as Gray Turner sign. Then we have Fox sign. In Fox sign, presence of Ecchymosis in the inguinal region is called as Fox sign. Then if you see the investigation of choice, CECT is the investigation of choice. This CECT is reserved for complications. So this CECT is actually the best time after 72 hours. It is done, the best time for CECT is after 72 hours. Then if you see the diagnosis, in the diagnosis we can do amylase test. This amylase is actually not very specific. Amylase is not very specific, and this amylase is raised in non-pancreatic causes, and there is no correlation between the amylase and the severity of the acute pancreatitis also. But the most specific is lipase is actually most specific. Lipase is most specific. Then if you see, CECT is the investigation of choice for diagnosis of most of the retropancreatic or retroperitoneal organs. So because pancreas is a CECT, pancreas is a retroperitoneal organ, CECT is also investigation of choice for pancreatic related disorders, like it is investigation of choice for pancreatic pseudosis, acute pancreatitis, pancreatic necrosis, carcinoma of pancreas. Also it is investigation of choice. Then CECT is also investigation of choice for conditions related to kidney. For conditions related to kidney also, CECT is the investigation of choice. Like for example, for autosomal dominant polycystic kidney disease, renal tuberculosis, renal cell carcinoma, angiomyolipoma, and renal oncocytoma, CECT is the investigation of choice. CECT is also investigation of choice for retroperitoneal fibrosis and retroperitoneal sarcomas. CECT is investigation of choice for retroperitoneal fibrosis and retroperitoneal sarcomas. Then if you see the management here, fluid of choice for this is Ringer lactate is the fluid of choice for acute pancreatitis. Then we can do oxygen supplementation can be done, and analgesics like NSAIDs can be given, which include methimazole is the NSAID which is given. You can give methimazole, and also you can also give opioids can be given, like you can give buprenorphine can be given. So in this the main treatment is analgesics. In the analgesics, NSAIDs can be given, which is metamazole, and opioids like buprenorphine can be given. And we can also give enteral nutrition can be provided, followed by total parenteral nutrition. Then if you see, indications of total parenteral nutrition include shock and severe acute pancreatitis are the indications of total parenteral nutrition. What are the indications of total parenteral nutrition? Are if the patient has shock or severe acute pancreatitis, then we give total parenteral nutrition. But in normal cases for acute pancreatitis, enteral nutrition is most preferred. Then in prognostic cases, we have Ranson's prognostic criteria. For non-Gallstone induced pancreatitis, in Ranson's prognostic criteria for non-Gallstone induced pancreatitis, we have two types. One, we have at the time of admission. Okay, second, we have after 48 hours. At the time of admission and after 48 hours. So at the time of admission, age of the patient is more than 55 years. Then WBC count is more than 16,000 per cubic millimeter, and if you see, RBC count is more than 200 milligram per deciliter, and LDH is more than 350 units per liter, international units per liter, and AST is more than 250 units per liter. So in the adult, at the time of admission, the age is more than 55 years, WBC count is more than 16,000 per millimeter cube, RBS, that is random blood sugar levels, is more than 200 milligram per deciliter, LDH is more than 350 international units per liter, and AST is more than 250 international units per liter. Then after 48 hours, if all in hematocrit is more than 10 points, and blood urea nitrogen is more than 5 milligram per deciliter, calcium is more than 8. Calcium is less than 8 milligram per deciliter, base deficit is more than 4 milli equivalent per liter, and we have arterial partial pressure of oxygen is less than 60 millimeters of Hg, and fluid sequestration is more than 6 liters. Fluid sequestration is more than 6 liters. So what are Ranson's prognostic criteria? At the time of admission, age is given, age of the patient is more than 55 years, WBC is more than 16,000 per millimeter cube, random blood sugar levels will be more than 200 milligram per deciliter, LDH is more than 350 and AST is more than 250. Then after 48 hours, fall in hematocrit is more than 10 points, blood urea nitrogen elevation is more than 5 milligram per deciliter, serum calcium is less than 8 milligram per deciliter, base deficit is more than 4 milli equivalent per liter, arterial partial pressure of oxygen is less than 60 millimeters of Hg, and fluid sequestration is more than 6 liters. So out of these 11 criteria, if more than 3 are present, then it is severe acute pancreatitis. If more than 3 are present out of these 11, then it is severe acute pancreatitis. Then we have BISAP score. So in BISAP score, we have blood urea nitrogen, B for blood urea nitrogen, M for impaired mental status, M for impaired mental status. Then we have S for severe inflammatory response syndrome, which complaints of temperature should be more than 38 degrees Celsius or less than 36 degrees Celsius, heart rate more than 90 beats per minute and respiratory rate more than 20 beats per minute, WBC more than 12,000 cells per millimeter cube or less than 4,000 cells per millimeter cube, or more than 10% of immature cells present in the peripheral blood. Then A for age is more than 60 years and also pleural effusion. So if any of these is present, if more than 3 are present, then it is severe acute pancreatitis. If it is 0 to 2 is present, it is less than 2% mortality. If it is 3 to 5 is present, more than 15% mortality is seen. So in BISAP score, that is bedside index for severity of acute pancreatitis, 1 we have blood urea nitrogen more than 25 milligram per deciliter, impaired mental status, severe immune response syndrome, severe inflammatory response syndrome, more than 2 out of 4 should be present, which include temperature more than 38 degrees Celsius or less than 36 degrees Celsius, heart rate more than 90 beats per minute, respiratory rate more than 20 beats per minute, WBC more than 12,000 cells per millimeter cube or less than 4,000 cells per millimeter cube, age more than 60 years, and pleural effusion. Then the next important score is we have QSOFA, that is Quick Sequential Organ Failure Assessment. According to Quick Sequential Organ Failure Assessment, respiratory rate more than 20 to 22 per minute. Then we have systolic blood pressure less than 100 millimeters of Hg, respiratory rate more than 22 per minute, and systolic blood pressure less than 100 per minute, and altered mental status can be seen. So altered mental status. Okay. QSOFA. In QSOFA, respiratory rate more than 22 per minute, systolic blood pressure less than 100 millimeters of Hg, and altered mental status. Respiratory rate more than 22 per minute, systolic blood pressure less than 100 millimeters of Hg, and alteration of mental status. If out of them nothing is present, then mortality is less than 1%. If 1 is present, then mortality is 2 to 3%. If more than or equal to 2 is present, then mortality is more than or equal to 10%. So this is about the quick sequential organ failure assessment. Then we have Apache 2. Then in Apache 2 we have acute physiology, and chronic health evaluation. In Apache 2 you will have acute physiology and chronic health evaluation too. So what do you see in this? In this we have BP, temperature, heart rate, respiratory rate are present. We have BP, temperature, heart rate, respiratory rate is present. We have serum creatinine, WBC count is seen, Glasgow Coma scale, and we have hematocrit. Then we see about oxygenation, pH, and potassium. So according to acute physiology and chronic health evaluation too, these include blood pressure, temperature, heart rate, respiratory rate, serum creatinine, WBC count, Glasgow Coma scale, sodium, hematocrit, oxygen, pH, and potassium. If more than or equal to 8 are present, then this suggests acute pancreatitis. Then what about the complications? First we have local complications for acute pancreatitis. We have to, in the acute stage, that is less than 4 weeks of stage, we have acute pancreatic fluid collection. First we have acute pancreatic fluid collection will be seen, and also we have acute pancreatic necrotic collection is seen. Acute pancreatic fluid collection and acute pancreatic necrotic collection is seen in acute cases. Then if you see in chronic cases, that is more than 4 weeks, you will have pseudocyst is seen, In more than 4 weeks, you will see presence of pseudosis, and also we see walled off necrosis is seen. Walled off necrosis is seen. So there are two types of local complications are seen. That is, in acute cases, you see it in less than 4 weeks where there is no defined wall, and here there is acute pancreatic fluid collection is seen and acute necrotic collection is seen. Then you have chronic stages, that is more than 4 weeks, you will see pseudocyst and walled off necrosis is seen. Then we have acute pancreatic fluid collection. In acute pancreatic fluid collection, one thing which we have is in the pancreas there will be fluid collection. This can be resolved spontaneously. It will resolve spontaneously, and in some cases after 4 weeks it can develop into pseudocyst. So in most of the cases, acute pancreatic fluid collection will resolve spontaneously. Then we have pancreatic abscess. Pancreatic abscess. In pancreatic abscess, if this is the pancreas, in the peripancreatic region there is pus collection is seen. In the peripancreatic region, you will see pus collection is seen in the peripancreatic region in pancreatic abscess. Then we have ultrasonography and CT guided percutaneous aspiration can be done. Along with that, you can give antibiotics also. So in pancreatic abscess, you have ultrasonography and CT guided percutaneous aspiration, and antibiotics can be given in pancreatic abscess. Then we have one more type which is called as pancreatic necrosis. So what do you see in pancreatic necrosis? In pancreatic necrosis, there will be non-viable pancreatic tissue will be seen with peripancreatic fat. There will be non-viable pancreatic tissue will be seen with peripancreatic fat. So this pancreatic necrosis is, that means the pancreas undergoes necrosis, and as a result it is actually a sterile condition, but it can undergo infection. Infection is actually a complication, and it is the most common complication of pancreatic necrosis. Infection from E. coli is most common complication of pancreatic necrosis. Then if you see, the drug with good penetration power is carbapenem. So for this pancreatic necrosis, you can give carbapenems can be used as the treatment because they have good penetrating power. So imipenem and meropenem can be used for treatment. So management is repeated pancreatic necrosectomy and surgical debridement can be done with ongoing lavage. You can do repeated pancreatic necrosectomy. Repeated necrosectomy can be done, and surgical debridement with ongoing lavage can be done. Then we have something called as Pancreatic Pseudo-Sister. In pancreatic pseudosis, this is actually the most common cystic lesion of the pancreas. Okay, here this pancreatic pseudocyst is actually a false cyst. It is a false cyst because it is not lined by epithelium, but it is actually lined by granulation tissue. It is not lined by epithelium, it is lined by granulation tissue. The most common cause of pancreatic pseudocyst is alcohol is the most common cause of pancreatic pseudocyst. Then if you see, most common site is lesser sac is the most common site of pancreatic pseudocyst. Most common cause of pancreatic pseudocyst is alcohol. Most common site of pancreatic pseudocyst is lesser sac is the most common site of pancreatic pseudocyst. Next we have acute pancreatitis differences. If you see, acute pancreatitis and chronic pancreatitis, both these can result in pseudocyst formation. So acute pancreatitis is either single or large pseudocyst will be seen, but in chronic pancreatitis you will see small and multiple cysts are seen in chronic pancreatitis. Then in acute pancreatitis you will see extrapancreatic cyst is most common. In chronic pancreatitis you will see intrapancreatic cyst is most common. Acute pancreatitis incidence is 10 to 12%, whereas chronic pancreatitis incidence is 20 to 40%. Acute pancreatitis you will see single and large cyst is seen which is extrapancreatic and incidence is 10 to 12%. In chronic pancreatitis, you will see multiple small cysts are present which are intrapancreatic and the incidence is 20 to 40%. Now, if you see the clinical features, in most of the cases, the pseudocysts are small. Because they are small, they are asymptomatic. There may be symptomatic patients will be seen where the patient will present with the abdominal pain will be seen with non-bilious vomiting is seen. So if you see what is the most common complication of pseudocyst, the most common complication of pseudocyst is infection followed by hemorrhage is the most common complication of pseudocyst. Then investigation of choice of pseudocyst is CECT is the investigation of choice for pseudocyst. Investigation of choice for pseudocyst is CECT. Actually, for many of the pancreatic issues, the investigation of choice is CECT. Then if you see the treatment, in the treatment you can give conservative management can be given so that the pseudocyst will resolve spontaneously, or you can also give indications for the surgery can be given. Like if the duration of pseudocyst is can be more than 6 weeks, or size of the pseudocyst can be more than 6 centimeters. Duration can be more than or equal to 6 weeks, or size can be more than or equal to 6 centimeters. Then if you see the surgery, in the surgery you can do the treatment of choice for the pseudocyst is actually cystojejunostomy is the treatment of choice for pseudocyst. Then most common performed procedure for pseudocyst is cystogastrostomy is the most common performed procedure. So most common treatment of choice for pseudocyst is cystojejunostomy, and most common performed procedure is cystogastrostomy is the most common performed procedure. You can also do cystoduodenostomy can be done. So in cystogastrostomy, if this is the stomach and if this is the pseudocyst, you will drain the pseudocyst into the stomach. The drainage is against the gravity. Since the drainage is against the gravity, sometimes the food particles which come from the stomach may come and they may lodge into the pseudocyst, and thus these food particles can attract infection or bacterial overgrowth, leading to some syndrome can also occur. Then the next we also have cystojejunostomy. We have cystojejunostomy, or also called as Roux-en-Y cystojejunostomy. In cystojejunostomy or Roux-en-Y cystojejunostomy, here the jejunum. In cystojejunostomy or Roux-en-Y cystojejunostomy, the jejunum is divided into proximal and distal limb. The jejunum is divided into proximal limb, and also it is divided into distal limb. Okay, the proximal limb is actually anastomosed with lower part of Roux-en-Y technique, whereas the distal limb is anastomosed with the cyst. Proximal limb is anastomosed with the lower part of Roux-en-Y technique, and distal end is anastomosed with the cyst. So it is almost similar. If this is the stomach, here this is the jejunum, and here this is the part we have cut. Okay, the distal part I will anastomose it. One part, proximal part is anastomosed to the, this part is anastomosed to the lower limb of the Roux-en-Y stump. Okay, and this Roux-en-Y stump, this is pulled up and anastomosed with the cyst which is present here. So this is how you see. This is cystojejunostomy is done. In this cystojejunostomy, the drainage is under the gravity. Because the drainage is under the gravity, there is no formation of some syndrome. The disadvantage of cystojejunostomy is here there is long duration of surgery is seen, and also you will see increased blood loss is seen, and also the surgery is of longer duration. Long duration of surgery you will see, and also you will see increased blood loss will be seen. Then if you see the mutations, which are associated with clinical pancreatic syndrome, in the mutations associated with clinical pancreatic syndrome, first we have hereditary pancreatitis, which include PRSS1 gene, which is cationic trypsinogen gene. Then we have next gene, which is idiopathic chronic pancreatitis gene, which is CFTR gene, and we have tropical calcific pancreatitic gene. Tropical calcific pancreatitic gene is SPINK1 gene. So here you have three genes are present. One, we have hereditary pancreatitis gene, PRSS1 gene, which codes for cationic trypsinogen gene. Then you have idiopathic chronic pancreatitis gene, which will code for CFTR gene, and we have tropical calcific pancreatitic gene, which is SPINK1 gene. Okay, now we have chronic pancreatitis. So first, in the chronic pancreatitis, here you will see presence of irreversible fibrosis of pancreatic parenchyma. You will see presence of irreversible fibrosis of pancreatic parenchyma along with the ongoing inflammation. Because of the fibrosis of pancreatic parenchyma, number one, there will be exocrine insufficiency will be seen, where more than 90% of the acini are destroyed. And this exocrine insufficiency will lead to the indigestion, it will lead to the malabsorption, and it will also lead to the steatorrhea. It will lead to the indigestion, malabsorption and steatorrhea. Whenever there is endocrine insufficiency, it will lead to the diabetes mellitus. Now, if you see the causes or etiology, etiology is most common cause of acute pancreatitis is heavy alcohol consumption. Heavy alcohol consumption is the most common cause of chronic pancreatitis. For chronic pancreatitis, we have a classification called as Tigaro classification, which is toxic, idiopathic causes are present, G for genetic causes, autoimmune causes are present, recurrent severe pancreatitis and obstructive pancreatitis is seen. So, what are the etiological features? These are Tigaro classification with toxic, idiopathic, genetic, autoimmune, recurrent, severe and obstructive pancreatitis is seen. Next, if you see the clinical features, in the clinical features you will see diabetes mellitus and you will see presence of the calcifications in the pancreas will be seen, and also you will see steatorrhea, which is fat malabsorption is seen. If you see what is the most common symptom, the most common symptom in this case is abdominal pain. Now, what about the investigation of choice? Investigation of choice is MRCP and gold standard is ERCP. This ERCP can be both diagnostic and therapeutic also. In this ERCP, you will see alternate dilatations of pancreatic duct is seen along with stricture formation. There is alternate dilatation of pancreatic duct along with stricture formation will be seen, and in the pancreatic duct you will see formation of pancreatic stones will be seen. These dilated parts you will see pancreatic stones. So all these are enclosed as string of pearl appearance, or also called as chain of lake appearance. These are enclosed as string of pearl appearance or chain of lake appearance. The main complication is calcium carbonate. Then we have endoscopic ultrasonography can be done. This endoscopic ultrasonography is the most accurate investigation. But investigation of choice is MRCP, but endoscopic ultrasonography is the most accurate investigation for diagnosis of minimum change in chronic pancreatitis. Then we have a criteria called as Roseman's criteria. According to the Roseman's criteria, it is mainly based on endoscopic ultrasonographic features where you will see pancreatic calcifications are seen and chain of lake appearance are seen. Then if you see the treatment because the patient will have the patient will have exocrine insufficiency. So because of the exocrine insufficiency, you will see there will be indigestion, malabsorption, mainly because of the non-secretion of the pancreatic enzymes. So as a result, in this case, you will have to supplement the patient with pancreatic enzyme supplementation should be done. And also in endocrine insufficiency, you can give insulin for diabetes mellitus, and for analgesics, you can give pain can be given for analgesics. And also for pain you can give analgesics, and then you can also give analgesics like NSAIDs are given, NSAIDs like metamizole. Metamizole is the drug of choice for chronic pancreatitis, and you can also give opioids like buprenorphine is given. Even after giving metamizole and buprenorphine, if the pain is not relieved, then you should do ERCP with stenting or oblique stone removal can be done. Even after that, if pain is not relieved, then you should give celiac ganglion blockade should be done, and if pain is not relieved even after that, then you can do surgery can be done. So these are the different steps of management. Now if you see surgery, in the surgery you have two things. One, you have drainage procedures are present. Second, you have resection procedures are present. Drainage procedures, first drainage procedure is you have Pusto's procedure is present. In Pusto's procedure, in this you have longitudinal pancreatico-jejunostomy is done. If this is the pancreas, you will cut open the pancreas here and you will attach the bowel loop here. So that the drainage can occur. So this is pancreatic Pusto's procedure, which is longitudinal pancreatico-jejunostomy is done. Then in the resection we have Bejer's procedure. In Bejer's procedure you have distal duodenal preserving pancreatic head resection is seen. Duodenal preserving pancreatic head resection is seen. Here you will resect the pancreatic head and you will anastomose with the jejunum. And you are not, this is the jejunum, okay, this is the duodenum. So you are preserving the duodenum and you are removing the head of the pancreas and anastomoting it with the jejunum. So this is Bejer's procedure is seen. Then this is the resection procedure. Then one more resection procedure which is important is Frey's procedure. In Frey's procedure, this is also called as local resection of head with longitudinal pancreatic jejunostomy. Local resection of pancreatic head with longitudinal pancreatic jejunostomy. So there is a longitudinal pancreatic jejunostomy, and you will resect the head and also remove some part of pancreatic tissue, and you will anastomose it with jejunum. So this is local resection of pancreatic head with longitudinal pancreatic jejunostomy is done. Then the next important procedure is about carcinoma pancreas. Okay, in the carcinoma pancreas is the most common genetic mutation associated with the carcinoma pancreas is KRAS mutation more than P16 mutation. If you were asked what is the most common genetic mutation associated with carcinoma gallbladder, then it is P53 more than KRAS mutation is most common genetic mutation associated with carcinoma gallbladder. Then if you were asked what is the most common genetic mutation associated with carcinoma stomach, is P53 more than COX2 is the most common genetic mutation associated with carcinoma stomach. So first, most common genetic mutation associated with carcinoma pancreas is KRAS mutation more than P16. Most common genetic mutation associated with carcinoma gallbladder is P53 more than KRAS. Most common genetic mutation associated in carcinoma stomach is P53 more than COX2 is the most common genetic mutation associated with carcinoma pancreas. Then, if you were asked about the risk factors, first we have established risk factors. Established risk factors includes tobacco smoking, and you have hereditary risk factors like hereditary pancreatitis is in hereditary non-polyposis colonic cancer, and you have hereditary breast carcinoma and ovarian carcinoma, ataxia telangiectasia, familial adenomatous multiple mole melanoma, and Peutz-Jeghers syndrome. So all these are associated with pancreatic carcinoma. So what are they? Hereditary factors like hereditary pancreatitis, which is autosomal dominant, hereditary non-polyposis colonic cancer, which is again autosomal dominant, hereditary breast and ovarian carcinoma, which is BRCA2, autosomal dominant, ataxia telangiectasia, which is autosomal recessive, familial atypical multiple mole melanoma syndrome, which is autosomal dominant, and Peutz-Jeghers syndrome, autosomal dominant. So all these are associated hereditary factors or genetic susceptibility. Then you have associations. In the associations, we have diabetes mellitus, obesity, and chronic pancreatitis are seen. So associated with carcinoma pancreas are diabetic mellitus, obesity, and chronic pancreatitis are associated with carcinoma pancreas. So if you see what is the most common type of carcinoma pancreas, adenocarcinoma is the most common type of carcinoma pancreas. Then if you see this non-specific marker, CEA is non-specific marker, but what is the specific marker? CA19-9 is a specific marker of adenocarcinoma of pancreas. CA19-9 is the specific marker for carcinoma of pancreas. Chemotherapeutic regimen given is gemcitabine is the chemotherapeutic regimen given, and most common site of metastasis is in the liver. It is most commonly seen in liver. Then what is the most common site of carcinoma pancreas? Carcinoma pancreas is most commonly seen in the head of the pancreas. It is more common than body than tail of the pancreas. Then this is also associated with intense desmoplastic reaction. Desmoplastic reaction is presence of lots of fibrosis in the pancreatic tumor. So what does the patient present with? The patient will present with the symptoms of jaundice mainly, followed by weight loss will be seen. And also the patient will have in the head of the pancreas, the patient will have jaundice followed by weight loss, and in the body and tail of the pancreas. See, if the tumor is present in the head of the pancreas, then this will grow and it will cause obstruction to the pancreatico duodenal or ampulla of Vater. Actually, once it gets obstructed, once this duct gets obstructed because of this, so the bile drainage will not occur, and as a result the patient shows jaundice. Okay, here the patient will have jaundice more than weight loss. And carcinoma head of pancreas, you will see jaundice is more commonly seen than weight loss. Then if you see, you can also see carcinoma body and tail of the pancreas. In the tumor can also be seen in body and tail of the pancreas. The tumor seen in body and tail of the pancreas is actually, it causes the symptom of weight loss. Carcinoma body and tail of the pancreas causes weight loss. Then we have ampullary carcinoma. The most common symptom of ampullary carcinoma is jaundice is the most common symptom of ampullary carcinoma. And there will be waxing and waning of jaundice is seen in these patients. This carcinoma of pancreas is also associated with migratory thrombophlebitis, which is called as Trousseau's syndrome. Then the next important thing is investigation of choice for diagnosis of carcinoma pancreas is CECT. And what do you see in CECT in the pancreatic carcinoma? You will see presence of antral pad sign is seen. You will see widening of the C-shaped loop is seen. And also you will see presence of three sign. This is 3 sign. Reverse 3 sign is seen with double duct sign. Also, you will see presence of double duct sign, reverse 3 sign is seen. So, those are the carcinoma pancreatic signs. What are they? Antral pad sign, widening of C loop, reverse 3 sign of Frostberg, double duct sign. Other signs like rose thorn appearance, mucosal irregularities, and scrambled egg appearance are also seen. Rose thorn appearance, mucosal irregularities, and scrambled egg appearance is also seen. Then management. The management mainly depends on the location. For example, carcinoma body and tail of the pancreas. If you see carcinoma body and tail of the pancreas, if the tumor is present in the body and tail, see if the tumor is present in the mainly in the body and the tail, then you can do distal pancreatectomy can be done. If it is a benign tumor, then obviously you can do enucleation can be done. If the tumor is present in the head of the pancreas, then you should do a procedure called as Whipple's procedure is done, which is actually pancreaticoduodenectomy. You do a Whipple's procedure, which is pancreaticoduodenectomy can be done. Or you can also do long wire traverso procedure can be done. Long wire traverso procedure can be done, which is actually a pylorus preserving pancreaticoduodenectomy should be done. Long wire traverso procedure, which is pylorus preserving pancreaticoduodenectomy can be done. Then if you see in advanced cases, gemcitabine is the treatment which is given for these patients. Then we have to learn what is Whipple's procedure. Whipple's procedure steps are important. The differences between Whipple's procedure and long wire traverso procedure. Whipple's procedure and long wire traverso procedure. In Whipple's procedure, we have pancreaticojejunostomy, hepaticojejunostomy, and gastrojejunostomy. Pancreaticojejunostomy, hepaticojejunostomy, and gastrojejunostomy is the Whipple's procedure. Then long wire traverso procedure, we have pancreaticojejunostomy, hepaticojejunostomy, and this is duodenojejunostomy. So Whipple's procedure, first we do pancreaticojejunostomy, then we do hepaticojejunostomy, then we do gastrojejunostomy. In long wire traverso procedure, we do pancreaticojejunostomy followed by hepaticojejunostomy, and also we do duodenojejunostomy is done. Then, if you see, most common site of anastomotic leak is pancreaticojejunostomy more than gastrojejunostomy more than hepaticojejunostomy is the most common site of anastomotic leak. Then what is the most common complication? Most common complication of pancreaticoduodenostomy is delayed gastric emptying is the most common complication of pancreaticoduodenostomy. In pancreaticoduodenostomy, the most common complication is delayed gastric emptying can occur. What is the most common cause of death? Most common cause of death is actually cardiopulmonary symptoms. Cardiopulmonary complications are the most common cause of death. Cardiopulmonary complications are the most common cause of death. Then what about the most important predictor of survival? Resection. RO resection will predict about the survival. Most important predictor of survival is RO resection is the most important predictor of survival. Then we have resections. In the resections, we have 3 types of resections. Then we have RO resections, R0 resections, R1 resections, and R2 resections. R0 resections have negative margin. R1 resectors have microscopic positive margin. R0 or R1 receptors have microscopic positive margin. R2 resection will have a macroscopic positive margin. It has macroscopic positive margin. So first R0 resection has negative margin. R1 resection has microscopic positive margin. R2 resection has macroscopic positive margin. So R1 is microscopic positive margin and R2 is macroscopic positive margin. Now, most important margin here is in pancreaticoduodenectomy is most important margin in pancreaticoduodenectomy is uncinate margin is most important, or also called as retroperitoneal margin, or also called as superior mesenteric vein margin. So most important margin in pancreaticoduodenectomy is uncinate margin, retroperitoneal margin, and superior mesenteric vein margin is the most important margin of pancreaticoduodenectomy. Then if you see the survival in carcinoma pancreas, so stage 1 and stage 2 survival is around 16 to 20 months. In stage 1 and stage 2, survival is around 16 to 20 months. In stage 3, survival is around 6 to 10 months. And in stage 4, the survival is around 3 to 6 months. So survival in carcinoma pancreas, stage 1 and stage 2, it is 16 to 20 months. Stage 3, it is 6 to 10 months. And in stage 4, it is 3 to 6 months. Then we have neuroendocrine tumors of pancreas. In neuroendocrine tumors of pancreas, most common neuroendocrine tumor of pancreas is non-functional tumor or PPOMA, pancreatic polypeptidoma, or non-functional tumor. Tumor is the neuroendocrine tumor of pancreas. Most common neuroendocrine tumor of pancreas is non-functional or pancreatic polypeptidoma. Then if you see this, then if you were asked what is the most common functional neuroendocrine tumor, most common functional neuroendocrine tumor is insulinoma. Then most common functional and malignant neuroendocrine tumor is gastrinoma. Most common functional and malignant neuroendocrine tumor is gastrinoma. Most common functional neuroendocrine tumor is insulinoma. Most common functional and neuroendocrine tumor of pancreas is gastrinoma. Then in the neuroendocrine tumors are actually symptomatic. Why? Because of the production of the active substances. They produce active substances, so they are symptomatic at early stage itself. So they are diagnosed at early stage and thus they are also treated at early stage. So as a result, they have better prognosis. So these neuroendocrine tumors have better prognosis than the adenocarcinoma. So if you see the prognosis in the pancreas, neuroendocrine tumors will have better prognosis than adenocarcinoma. They have better prognosis than adenocarcinoma. Then if you see the diagnosis in lab is mainly by measuring the active substance. It is mainly by measuring the active substance. So if you see, investigation of choice for localization of neuroendocrine tumor is called as somatostatin receptor scintigraphy is the investigation of choice for localization in neuroendocrine tumor. Has all neuroendocrine tumor express somatostatin receptors except insulinoma. So you can do somatostatin receptor scintigraphy is the investigation of choice which can be done in all the tumors except insulinoma. So what is insulinoma? Insulinoma is a functional it is actually the most common functional neuroendocrine tumor. It is a benign tumor mostly. It is most commonly seen in head is equal to body is equal to tail is equal to, so that is equally distributed in head, body and tail of the pancreas. It will produce insulin. So insulin will cause breakdown of the glucose and thus it will result in hypoglycemia. And also you will see blood glucose levels of 45 to 50 milligram per deciliter are seen. Blood glucose levels of 45 to 50 milligrams of per deciliter of blood glucose level is seen. Here, because of the decreased blood glucose level, the patient presents with dizziness, headache, confusion and coma. There are also sympathetic overactivity occurs due to palpitations, tachypnea and excessive sweating will cause sympathetic overactivity. Here, the patient will have painless condition. This insulinoma is a painless condition which is associated with weight gain. So if you see the diagnosis, in the diagnosis, the gold standard diagnosis is 72-hour fasting is the gold standard diagnosis. For insulin glucose ratio is 0.4 is diagnosis. After 72 hours fasting, the insulin to glucagon ratio more than 0.4 is diagnostic. So if you see the preoperative test for localization, here the insulinomas you would not do somatostatin receptor scintigraphy for insulinomas. So for insulinomas you will have to do preoperatively, you should do intra-arterial calcium injection should be done. Here intra-arterial calcium injection with portal venous blood sampling should be done. Intra-arterial calcium injection with portal venous blood sampling is done. So in insulinoma, the best preoperative test for localization is intra-arterial calcium injection with portal venous blood sampling is done. Then what about the overall best investigation? Then overall best investigation is, you will see endoscopic ultrasonography is overall best investigation along with intraoperative palpation. There is endoscopic ultrasonography with intraoperative palpation is done, is the overall best investigation. But preoperatively, you can evaluate using intra-arterial calcium injection with portal venous blood sampling. So for the management, we give diazoxide and octreotide are given preoperatively, mainly to control the hypoglycemia. To control hypoglycemia, we give diazoxide and octreotide are given. If the tumor is in the head of the pancreas, you can just enucleate the tumor. If the tumor is in the tail or body of the pancreas, then you can do distal pancreatectomy can be done to the patient. Then the next important is we have gastrinoma, also called as Zollinger-Ellison syndrome. Gastrinoma and Zollinger-Ellison syndrome is most common functional and malignant neuroendocrine tumor. It is the most common functional and malignant neuroendocrine tumor of pancreas is gastrinoma or Zollinger-Ellison syndrome. Then what is the most common site? The most common site is duodenum. More than pancreas is the most common site. In the duodenum, it is most commonly seen in first part of duodenum, followed by second part, followed by third part of duodenum. Fourth part of duodenum is not involved in gastrinoma. Gastrinoma, 75% of the cases are sporadic case, whereas 25% are associated with MEN1 tissue. MEN1 tumors. Then 90% of the cases of gastrinomas, we have triangle of Passaro is present for 90% of cases. The triangle of Passaro is, where do you see triangle of Passaro? So if this is the gallbladder, so for this you will see you will put 3 points. One at the junction of head and neck of the pancreas, second at the junction of second and third part of duodenum, and third at the junction of common bile duct and the cystic duct, and you will draw a triangle. This triangle which is shown here, this is actually the Passaro triangle, okay, or also called as gastrinoma triangle. What is this? This is actually Passaro triangle or gastrinoma triangle. So this is gastrinoma. So in gastrinoma, you will see presence of increased gastrin is seen. Gastrin production, which will increase the acid and which will also increase the results in peptic ulcer disease will occur. So if you see the other clinical manifestations, the most common symptom is abdominal pain is the most common symptom in this patient, along with the retrosternal heartburn will be seen, and also there will be symptoms of dyspepsia, diarrhea are seen. Here the patient can present with large ulcers and multiple ulcers, and also jejunal ulcers may be seen. And remember, there will be ulcers are present in some unusual sites in gastrinoma. So if you see the diagnosis in the gastrinoma, the gastrin is more than 1000 picogram per ml, which is diagnostic, and the basal acid output more than 15 milli equivalent per hour. Okay, the gastrin is more than 1000 picogram per ml, which is diagnostic, and basal acid output of more than 1.5 milli equivalent per liter is diagnostic. Then what is the best provocative test? The best provocative test is actually secretin stimulation test. Is the best provocation test where you do release of gastrin is done more than 200 picogram per ml. okay, where the release of gastrin is more than 200 picogram per ml. So the best provocative test is secretin stimulation test is the best provocative test. Then what is the investigation of choice? Investigation of choice is somatostatin receptor scintigraphy is the investigation of choice. Then what about the drug of choice? The drug of choice is proton pump inhibitors are the are used for gastrinoma, and for treatment of choice we have to use pylorus preserving Whipple's procedure is used as the treatment of choice. Pylorus preserving Whipple's procedure is used as the treatment of choice. Then we have glucagonoma. Okay, in the glucagonoma, we have something called as 4Ds. So what do you see in 4Ds? Diabetes mellitus, you will see dermatitis, diabetes mellitus, dermatitis, DVT, that is deep vein thrombosis, and depression are seen. You will see diabetes mellitus, dermatitis, deep vein thrombosis, and depression are seen. This glucagonoma is mainly seen in the body and tail of the pancreas. It is mainly seen in the body and tail of the pancreas. The investigation of choice is increased glucagon levels are seen in this patient, and also investigation of choice for localization is actually somatostatin receptor scintigraphy is the investigation of choice for localization. So if you see the treatment is because it is present in the tail and the body of pancreas, you should do distal pancreatectomy is done in these patients. Then we have a disease called as Vipoma or Werner-Morrison syndrome, or we have pancreatic cholera, or we have VDHA syndrome. So you have Vipoma, pancreatic cholera, VDHA syndrome, or Werner-Morrison syndrome is present. So this Vipoma, Werner-Morrison syndrome, pancreatic cholera, and VDHA syndrome, here you will see presence of watery diarrhea is seen, which is 4 to 6 liters of watery diarrhea is seen. This watery diarrhea will cause decrease in sodium, decrease in chloride, hypokalemia, hypocalcemia, hypokalemia, and decreased bicarbonate is seen. And also you will see presence of increased random blood sugar levels and increased calcium, that is hypercalcemia, and hyperglycemia is seen. So if you see watery diarrhea is seen in 4 to 6 liters, where you see the patient presents with hypokalemia, hypochloremia, hypokalemia, with decreased with acidosis. This is acidosis, like decreased bicarbonate with the increased random blood sugar levels and increased calcium are seen. Most common site is actually tail of the pancreas is the most common site, and it has a medical emergency. This Vipoma is a medical emergency. Then if you see the diagnosis, in the diagnosis, vasoactive inhibitory intestinal peptide. Vasoactive intestinal peptide levels are important in diagnosis. Diagnosis is by vasoactive intestinal peptide, and investigation of choice for localization is somatostatin receptor scintigraphy is the investigation of choice for localization. Diagnosis is vasoactive intestinal peptide, and investigation of choice is somatostatin receptor scintigraphy. Then if you see the management is you should do fluid resuscitation with correction of dyselectrolytemia should be done. Fluid resuscitation with correction of dyselectrolytemia is done, and you can also give octreotide to the patient. Octreotide will help to control the preoperative diarrhea. Then treatment of choice in this condition is distal pancreatectomy is the treatment of choice for Vipoma. So diagnosis is vasoactive intestinal peptide levels, and investigation of choice is somatostatin receptor scintigraphy. Then treatment is you should do fluid resuscitation with correction of dyselectrolytemia is done, and octreotide can be given to control the preoperative diarrhea, and treatment of choice is distal pancreatectomy can be done. Then we have cystic neoplasm of pancreas. In the cystic neoplasm of pancreas, we have the most common cyst of pancreas is actually the pseudocyst. The most common cyst of pancreas is pseudocyst. Then what is the most common cystic neoplasm of pancreas? Most common cystic neoplasm of pancreas is Mucinous System. Is the most common cystic neoplasm of pancreas. Next we have Cystic Neoplasm. Cyst neoplasm, or we have adenoma. Cystic Neoplasm and adenoma is seen. This cystic neoplasm is actually a benign neoplasm, the most common site being the head of pancreas. It is a benign neoplasm seen in the head of the pancreas. Most commonly, it is seen in the females in 5th to 6th decades of life. Then if you see the pathological features here in cystic neoplasm, this is microcystic, and you will see sponge-like, honeycomb-like appearance are seen. In cystic neoplasm, it is sponge-like, and you see microscopic cystic sponge-like honeycomb appearance is seen. And clinical features are, most of the cases are asymptomatic, and in symptomatic patients you will see appearance of vague abdominal pain is seen in the symptomatic patients. Appearance of vague abdominal pain is seen, and investigation of choice is CECT scan can be done. On CECT with Pseudo-Sister, you will see presence of central stellate scar is seen. You will see presence of central stellate scar is seen, and you will also see presence of central sunburst calcification is seen. Now, on aspiration of the cyst, you will see that the serous cyst, because this is a Pseudo-Sister, you will see that serous content is seen, and carcinoembryonic antigen is decreased, and amylase is also decreased. Carcinoembryonic antigen and amylase is decreased on aspiration of the cyst. Then if you see the treatment include observation you can do, and you can also do resection. And resection is mainly done or indicated if there is diagnostic uncertainty. It is indicated if there is diagnostic uncertainty, if the patient is symptomatic, and if the size of the patient is more than 4 centimeters, then we do resection. So, treatment of this Cystic adenoma is you can do observation, and you can resection is done, is indicated if diagnostic uncertainty is present, or if there is symptomatic tumors, or if size is more than 4 centimeters, then you can do resection. Then we have mucinous system. Mucinous cystic neoplasm, or we have mucinous cystadenoma. In mucinous cystic neoplasm or mucinous cystadenoma, it is the most common cystic neoplasm which is present in pancreas. It is most common cystic neoplasm of pancreas. This mucinous cystic neoplasm is actually a pre-malignant lesion. Okay, it is most commonly seen in females, and most common site is actually the body, and the tail of the pancreas is the most common site of the lesion. The pathological features are, here you will see macrocystic appearance with the clinical features include, you will see that the patient is symptomatic with vague abdominal pain will be seen. On investigation of choice is CECT. On CECT you will see presence of peripheral eggshell calcification is seen. On CECT you will see presence of peripheral eggshell calcification is seen on CECT. Okay, then if you see the cyst, the main content of the cyst is mucin is the main content of the cyst, and here carcinoembryonic antigen is increased in the cyst, and amylase is decreased. Carcinoembryonic antigen is increased and amylase is decreased in this case. Carcinoembryonic antigen is increased and amylase is decreased. So if you see the treatment is you can do surgical resection of the tumors can be done. Surgical resection of tumors can be done in mucinous cystadenoma. Then you have intraductal papillary mucinous neoplasm. In intraductal papillary mucinous neoplasm, this intraductal papillary mucinous neoplasm is actually a pre-malignant condition. Okay, it is most commonly seen both in females and males. The most common site of intraductal papillary mucinous neoplasm is mainly in the head and the uncinate process. Most common site is of intraductal papillary mucinous neoplasm is head and the uncinate process. So, this intraductal papillary mucinous neoplasm is of 3 types. One, we have main duct variety. Second, we have side branch variety. And third, we have mixed variety. Main duct variety. Second, we have side branched variety. And third, we have mixed variety. So, what are the clinical features? Here in intraductal papillary mucinous neoplasm, the patient presents with recurrent attacks of acute pancreatitis and abdominal pain is seen. Investigation of choice for intraductal papillary mucinous neoplasm is, you will see, endoscopy is done, is the investigation of choice. On endoscopy, you will see presence of fish mouth opening is seen. On endoscopy, you will see presence of mucin which is extruding through large fish mouth opening. Fish mouth opening can be done. Then, on aspiration of the cyst, On aspiration of the cyst, the content of the cyst will be found to be mucinous in content, which is carcinoembryonic antigen will be increased, and also amylase will be increased. Mucinous in content, carcinoembryonic antigen is increased, and amylase is also increased in these patients. Okay, mucinous content with carcinoembryonic antigen is increased and amylase is increased. Treatment is actually partial pancreatectomy is the treatment of choice for intraductal papillary mucinous neoplasm. Partial pancreatectomy is the treatment of choice for intraductal papillary mucinous neoplasm. Then the next important thing is about the esophagus. In the esophagus, the length of the esophagus is 25 centimeters and extent of the esophagus is C6 to T12 is the extent of the esophagus. In endoscopy, you have three narrowings are present. First, the first narrowing is present at the beginning of the cricopharynx. You will see the first narrowing at the beginning of the cricopharynx, which is 15 centimeters from the incisors. If you see it from the incisors, it is 15 centimeters from the incisors, and there will be arch of aorta will be seen where you see the one more narrowing. This arch of aorta narrowing where arch of aorta is seen. This is 25 centimeters from the upper incisors, and here only you will see appearance of left bronchus will also be seen. Even this is at 25 centimeters, and at the end the esophagus will pierce the diaphragm and reach the abdomen. It is 40 centimeters from the upper incisors. Okay. Now, if you see the lining of the esophagus if this is the esophagus, upper 1/3 is actually lined by stratified squamous epithelium. It is lined by stratified squamous epithelium, whereas middle 1/3 is lined by mixed epithelium. I'm really sorry. Okay, the whole of the esophagus, it is actually lined by stratified squamous epithelium. The upper 1/3 has stratified muscle fibers. They have stratified muscle fibers are present in upper 1/3. Middle 1/3 they will have mixed fibers are present, and lower 1/3 they will have smooth fibers will be present. So upper 1/3 you have stratified muscle fibers will be present. Lower 1/3 you will have smooth muscle fibers are present. Middle 1/3 you will have slow transition from stratified muscle fibers to smooth muscle fibers will occur in middle 1/3 mixed muscle fibers. Lower 1/3 you will see smooth muscle fibers will be present. So what are the characteristics of esophagus? One important characteristic is in the esophagus it does not have villi. It has a stratified squamous epithelium only. It does not have any villi. There is no keratinization will be seen. No villi is seen. No secretions. No plexus also. There are no villi, no secretions, no Meissner's plexus. It has only one plexus is present, which is Auerbach plexus are present, but Meissner's plexus. Auerbach plexus are present, but Meissner plexus are actually absent in this case. In this case, it lacks serosa, no villi is seen, no secretions are seen, no Meissner's plexus are seen. If it has single plexus are only present, so in the single plexus, Auerbach plexus are only present. Then, one unique feature of the esophagus is presence of lymphatics. Is the unique feature in the esophagus. Lymphatics are mainly present in the lamina propria. Lymphatic is mainly present in the lamina propria in the esophagus. Then if you see this esophagus, one-liners, this is the narrowest portion. This is the narrowest part of the GIT. It is the narrowest part of the cricopharynx also. In case of sharp bodies or buttons, intervention has to be done to remove them. Otherwise, they can be absorbed into the GIT. So whenever if someone eats or someone swallows the sharp foreign bodies or button particles, we should do intervention should be done. Okay. So this is about the esophagus introduction. Thank you, and thank you for watching.